Imagine trying to start a family, right? But only to discover that your own immune system has built this literal physical wall blocking the way.
Yeah, that's exactly what it feels like.
Because today we are looking at a really tough diagnosis. It's one where the internal biology of fertility is actually perfectly fine, but the physical anatomy is under this active, relentless attack.
Right, and that disconnect is, well, it's what makes this specific condition so uniquely devastating for patients, you know.
I can only imagine.
You have the internal engine of reproduction primed and ready to go, but the structural entry point is just severely compromised.
Yeah.
The psychological toll of that paradox is immense.
Oh, absolutely. And if you are listening to this right now, you are probably here with a very specific, highly personal mission. You, or maybe your partner, have been handed a diagnosis and you're staring down one massive, terrifying question.
Can lichen sclerosus actually cause fertility problems?
Exactly. Can a skin condition actually stop you from starting a family?
It's a question that, frankly, brings a profound amount of silent suffering to couples. They just feel completely isolated by it.
Well, our goal today is to break that isolation. We are diving deep into lichen sclerosus, often just called LS, and its direct impact on conception, pregnancy, and childbirth.
And we've brought the receipts for this one.
We really have. To get to the absolute bottom of this, we've pulled a robust stack of clinical sources. We're looking at the UK national guidelines from the British Society for the Study of Vulval Disease, some really extensive clinical treatment reviews, and even comprehensive patient FAQs from specialized women's health clinics.
It's a fascinating mix of material, really, because it blends that high-level dermatological and gynecological data with the raw, on-the-ground questions patients are, like, desperately asking their specialists behind closed doors.
Yeah, the stuff they're Googling at 2 a.m.
Yeah.
So let's address the most panic-inducing fear right out of the gate. Does lichen sclerosus biologically break the machinery of conception? Like, if a patient has this autoimmune condition, are their eggs, their ovaries, their uterus somehow damaged by the inflammation?
The direct answer is no. Period. Lichen sclerosus does not affect your internal reproductive organs in any way.
Wait, really? Not at all?
Not at all. Your uterus, your fallopian tubes, your ovaries, they remain completely untouched by this disease.
Huh. That actually feels kind of counterintuitive for an autoimmune disease, right? Usually we think of systemic conditions affecting the whole body.
Yeah, I mean, many autoimmune diseases do behave systemically, but LS is highly localized. It has a strong, almost exclusive predilection for the anogenital area.
Okay.
In women, it typically presents in this characteristic figure-of-8 pattern, looping around the vulva and the perianal region. And furthermore, having LS does not lower your overall systemic immune function in a way that, say, prevents a fertilized egg from implanting.
Oh, wow.
So biologically speaking, the internal environment for creating a child is perfectly intact.
Okay, that should be a massive relief for anyone listening.
Absolutely.
But it immediately forces us to confront the reality on the surface. Because if the internal biology is fully functional, why is getting pregnant still such a mountainous, agonizing hurdle for so many people with LS?
Because while the biology is intact, the physical architecture of the tissue is being systematically altered by chronic inflammation.
Break down that mechanism for us. Like, what is the immune system actually doing to the skin?
Well, the exact trigger remains elusive, but we do know the mechanism. T cells, which are basically the immune system's foot soldiers, they inappropriately aggregate in the dermis, the deep layer of the skin,
Okay.
and they release a cascade of inflammatory cytokines. This chronic inflammation essentially scrambles the skin's normal collagen production.
And the sources describe the visual and structural result of the scrambled collagen in very stark terms. It is not just your standard rash.
Far from it. The tissue fundamentally loses its elasticity and resilience. In some areas, the skin can become thickened, white, and leathery, but in other areas, it becomes incredibly thin and fragile. The clinical literature actually describes this thinned tissue as looking like cellophane paper.
Cellophane paper, geez. Just visualizing that texture in a highly sensitive, intimate area, I mean, it makes you wince.
Yeah.
It implies something that will just tear the second it's stretched.
Which is exactly what happens.
Yeah.
Because the tissue loses its structural integrity, you start seeing severe anatomical changes. Patients experience labial fusion, where the inner lifts of the vulva actually stick and fuse together as the body tries to heal the constant inflammation.
Oh my God.
You also see introital stenosis, which is the medical term for a severe, rigid narrowing of the vaginal opening.
Okay, I want to try to visualize this disconnect between the internal biology and the external reality.
Sure.
It's essentially like owning a house where the inside, the living room, the kitchen, the bedrooms, is pristine and perfectly maintained. But the front gate of the property has rusted completely shut and it's wrapped in barbed wire. Like entering the house is biologically possible, but mechanically, it's agonizing.
That is a brutally accurate analogy.
Yeah.
The house is ready, but the gate is fused. And the cruelty of this disease becomes even more apparent when we look at a phenomenon mentioned in the clinical guidelines. It's called the Koebner response.
Yes. This stood out to me in the research as the ultimate catch-22 for any couple trying to conceive. How does the Koebner response actually work on a biological level?
So the Koebner response is a phenomenon where physical trauma or friction applied to the skin actually summons the disease to that specific site.
Wait, friction.
Yeah. When the skin experiences friction, it causes microscopic trauma. The body responds to that microtrauma by releasing signaling proteins, essentially shooting off a flare gun.
Okay.
Now, in a healthy person, those signals just promote normal healing. But in an LS patient, that flare gun calls those confused, aggressive T cells directly to the area, triggering a massive inflammatory flare-up.
Which means, and this is the really tragic irony here, the very act required to get pregnant, sexual intercourse, creates the exact mechanical friction that feeds the disease.
It creates a devastating cycle. The friction of intercourse triggers the Koebner response. The inelastic, cellophane-like skin cannot stretch to accommodate the friction, so it splits.
Ugh.
These painful tears are called fissures, and they most commonly occur at the bottom of the vaginal opening, an area known as the posterior fourchette.
It is entirely logical that a patient would develop an aversion to intimacy if every attempt at conception results in agonizing, tearing, bleeding, and, days of burning pain.
The medical term for that pain is dyspareunia. And over time, it frequently evolves into apriunia, which is the complete inability to have intercourse at all.
Wow.
The psychological friction this causes within a relationship is profound. The mechanics of conception become a source of absolute dread rather than connection.
And we also need to acknowledge that this mechanical barrier isn't exclusively a female issue, because our clinical sources explicitly note that men can also develop lichen sclerosus.
They absolutely do. In men, it is sometimes historically referred to as balanitis xerotica obliterans.
That's a mouthful.
Yeah, it's a very old school term. It predominantly affects the foreskin and the glands or tip of the penis. But the underlying autoimmune mechanism is exactly the same. The skin thickens, loses elasticity, and scars.
Which creates a parallel mechanical barrier during intimacy.
Precisely. In men, this often leads to a condition called phimosis, where the foreskin becomes so rigid and tight that it just cannot be retracted.
Right.
This causes intensely painful erections and severe tearing during intercourse. So if the male partner have LS, or if, heaven forbid, both partners happen to suffer from it, the friction-induced trauma is amplified, making conception even more difficult.
Okay, so if the body's own friction response is constantly fighting us, how does modern medicine actually dismantle that physical wall? We have this rusted, barbed wire gate. What is the medical equivalent of bolt cutters here?
Well, the gold standard treatment, which is emphatically supported by the BSSVD guidelines, is the diligent application of ultra-potent topical corticosteroids.
The sources specifically highlight clobetasol propionate.
Yes, typically at a 0.05% concentration. This is not the mild hydrocortisone you buy over the counter for a bug bite.
Right.
This is an ultra-potent prescription-grade medication. Its primary function is to rapidly suppress the localized autoimmune response. By shutting down the T cells in that specific area, it halts the inflammation, stops the maddening itch, and most importantly for patients trying to conceive, it softens that hyper-thickened skin.
Okay, here is where I have to push back, because reading through the patient FAQs, there is a glaring contradiction that absolutely sends people into a spiral of anxiety.
The warning label.
Yes. If a patient goes to the pharmacy and picks up a tube of clomidosol, the warning label printed on the box or on that little paper insert explicitly screams in bold letters, "Do not use on genitals."
Yeah, it's terrifying.
Right. Why are specialists prescribing a medication for the most sensitive area of the body when the manufacturer explicitly forbids it?
It is a massive source of panic for newly diagnosed patients. But understanding the underlying pharmacology clears up the contradiction entirely. You have to understand why that generic warning exists in the first place.
Okay, let's hear the mechanism. Why is it normally dangerous?
Topical steroids work by inhibiting collagen synthesis. On normal, healthy skin, which is already quite thin in the genital area, inhibiting collagen, causes a side effect called skin atrophy.
Meaning the skin gets even thinner.
Exactly. The skin thins out too much, becoming fragile and prone to tearing. That is why the manufacturer slaps that generic warning on the box for the general public, using steroids for standard rashes.
But the tissue affected by lichen sclerosus is not normal, healthy skin.
Exactly the opposite. The pathology of LS creates hyper-thickened, rigid skin that is just packed with disorganized collagen. The tissue is already fundamentally altered.
Oh, I see where you're going with this.
Right.
Yeah.
Therefore, the very side effect that makes steroids dangerous for normal skin, that thinning and breaking down of collagen, is the exact mechanical cure needed to reduce the hardened LS tissue back to a normal, pliable state.
That is a phenomenal clarification. So the side effect is actually the mechanism of the cure.
When used under the guidance of a specialist, ultra-potent steroids are incredibly safe and highly effective for genital LS. Weak, over-the-counter creams simply lack the horsepower to penetrate that thickened tissue and halt the inflammation. Patients really must trust the clinical guidelines over the generic warning label.
Okay, let's look at a scenario where the patient is diligent with the heavy-duty steroids. The active inflammation is shut down, the burning stops, but there's permanent structural scar tissue left behind that the steroids simply cannot dissolve.
Right, that happens.
The BSSVD sources outline a surgical intervention for this specific roadblock.
Surgery is very cautiously approached in LS, mostly because the act of cutting the skin can trigger that dreaded Koebner response we discussed earlier.
Yeah.
Surgery is the ultimate trauma.
Right.
However, for a very specific subset of patients, it is an absolute game changer.
The sources refer to a procedure called the double Z-plasty with VY advancement. It sounds like an incredibly complex piece of origami.
It's a brilliant application of plastic surgery principles, really. It's specifically designed for patients who suffer from isolated, persistent splitting at the posterior fourchette.
The bottom of the opening.
Exactly. This means the skin at the very bottom of the vaginal opening remains so tight that it splits open every single time they attempt intercourse, regardless of how much steroid cream they use.
How does refashioning the skin structurally solve a tension problem, though?
Think of the scar tissue like a short, tight rubber band stretched across the opening. When pressure is applied, it snaps. A surgeon performs the Z-plasty by making incisions in the shape of a Z directly over that tight scar band. This creates two triangular flaps of skin.
Oh, the sources sometimes refer to this as a jumping man flap, right? Based on how the lines are drawn on the skin.
Yes. And by carefully lifting and swapping the positions of those two triangular flaps, the surgeon fundamentally alters the geometry of the tissue. They break up the linear line of the scar.
It's basically an engineering solution. They are changing the vectors of tension.
That is precisely what it is. It redistributes the mechanical tension away from the point of impact and significantly elongates the tissue. This releases the contracture. So when the area heals, the newly arranged skin can stretch normally during intercourse instead of hitting a rigid limit and tearing.
Wow. Okay, so whether through the diligent application of ultra-potent steroids to soften the tissue or a highly targeted Z-plasty to release the tension, the mechanical barrier is dismantled. The couple is finally able to conceive.
The house is accessible.
The house is accessible, but that introduces a completely new biological variable. What happens to this aggressive autoimmune skin condition during the 9 months of pregnancy?
Here we have to look at the fascinating interaction between autoimmune diseases and the maternal immune system.
Right, because pregnant women famously undergo a systemic immune shift, so their body doesn't reject the fetus, which is essentially made of foreign DNA. Does that required immune downregulation just cure the lichen sclerosus?
The clinical data leans heavily toward the positive, though I wouldn't call it a universal cure. Pregnancy requires the maternal body to temporarily suppress certain aspects of cell-mediated immunity to tolerate the fetus.
Okay.
And because LS is driven by those aggressive T cells we mentioned earlier, this maternal downregulation often inadvertently suppresses the disease.
The clinical guidelines cited a prospective study that had some very encouraging numbers on this, didn't they?
Exactly. In that specific study, 45% of pregnant women with LS saw a dramatic improvement in their symptoms. Their tissue softened, the itching subsided, and they required significantly less topical steroid treatment to maintain comfort.
I mean, almost half of the patients experiencing a reprieve is a wonderful statistic.
It truly is. However, we do have to look at the other half of the data. Some women experience no change at all. Their symptoms remain completely stable. and a minority will unfortunately experience severe flare-ups during the gestation period.
Oh, wow.
Because this immune response is somewhat unpredictable, there is a non-negotiable rule regarding treatment during pregnancy.
And the sources are very loud about this. You must keep using your topical steroids.
Adherence is paramount. Many patients have this deeply ingrained reflex to stop all medications the moment they see a positive pregnancy test.
Yeah.
They just fear harming the baby.
Sure, it's instinctual.
But the BSSVD guidelines are emphatic here. Continuing, your ultra-potent topical steroid is perfectly safe for fetal development.
Because it's a localized treatment, not a systemic one, so the absorption into the bloodstream is minimal.
Correct. And more importantly, continuing the steroid is crucial for maternal health. You need to keep that tissue soft, elastic, and free of inflammation to physically prepare for childbirth. If you abandon the steroids, the T cells return, the inflammation ramps back up, the skin hardens, and you are just setting the stage for severe complications during delivery.
Now, while the steroids are a green light, the clinical reviews list a few medications that are strictly forbidden. Like, if a patient with stubborn LS was prescribed systemic treatments before conceiving, they need to scrutinize their medication list immediately.
This is a vital safety checkpoint. Some patients with severe treatment-resistant LS are prescribed oral medications. If a patient is using retinoids, which are powerful vitamin A derivatives like acitretin, they are absolutely contraindicated in pregnancy.
The washout period for retinoids is staggering. The guidelines state they are contraindicated for pregnancy and must be stopped at least 2 years prior to attempting conception.
Yes.
Why 2 years?
Well, retinoids are highly teratogenic, meaning they cause severe birth defects. The 2-year timeline exists because retinoids are lipophilic, they love fat, they get absorbed and stored deep within the body's adipose tissue or fat cells.
Oh, I see.
It takes literal years for the body to metabolize and clear those stores completely.
That is a critical conversation to have with a specialist long before trying to conceive.
Definitely. Additionally, if a patient is managing their LS with topical calcineurin inhibitors, such as tacrolimus or pimecrolimus creams, which suppress the immune system differently than steroids, those must also be paused during pregnancy and breastfeeding, as their safety profile for the fetus is just not as robustly established.
Okay, let's move the timeline forward. The patient has safely navigated the 9 months. The inflammation has been kept at bay with steroid maintenance. Now comes the main event, the hurdle that generates the most profound anxiety for LS patients' childbirth.
The anxiety is palpable. Studies indicate that up to 50% of pregnant patients with LS report significant, sometimes debilitating anxiety, specifically related to how they will deliver the baby.
It is entirely understandable. I can hear the listener's internal monologue right now. Like, if my skin is already structurally compromised, if it's prone to tearing from basic friction, how on earth can it survive a human head passing through it? Am I automatically guaranteed a C-section?
We can definitively bust that myth right now. Having lichen sclerosus is not a medical contraindication for a vaginal delivery. The vast majority of patients with LS go on to have entirely successful, safe vaginal births.
So the diagnosis itself doesn't automatically put you on the operating table.
It does not. But the operative phrase here is well-controlled LS. This circles back to why maintaining that steroid regimen throughout the pregnancy is so absolutely critical. The tissue needs to be as pliable and inflammation-free as possible.
To aid in that pliability, the clinical sources highlight a specific physical preparation technique.
They highly recommend perineal massage starting around the 34th week of pregnancy.
How does that help mechanistically?
It involves gently stretching and massaging the perineum, which is the tissue between the vagina and the anus. By applying consistent, gentle mechanical stretch over several weeks, you're physically breaking down minor adhesions and encouraging the skin to expand.
Okay, so it's physical training for the skin.
Basically, it helps the tissue acclimatize to the sensation of stretching, which is especially important if there is any mild underlying scarring from the LS.
Right. So the baby arrives safely, the delivery is successful, but our deep dive cannot end there because the sources raise a massive red flag about the postpartum period.
The weeks following childbirth represent arguably the most high-risk time for a severe LS flare-up. We have to think back to the Kopner response, the phenomenon where physical trauma triggers the autoimmune attack.
Because there is no physical trauma to the pelvic floor more intense than a vaginal birth, you have extreme perineal stretching, likely some degree of tearing, and potentially stitches.
You have massive localized trauma. And you combine that friction with a sudden, dramatic crash in pregnancy hormones, particularly estrogen, which normally helps keep vaginal tissue healthy.
Wow.
Then you add the intense psychosocial stress, the sleep deprivation, and the physical exhaustion of caring for a newborn,
It is the absolute perfect storm to wake up those aggressive T cells.
which leads to the most crucial piece of postpartum advice for an LS patient. You cannot afford to confuse an LS flare with normal healing pain.
That's tough because society expects new mothers to be in pain, so they often just grit their teeth and suffer in silence, assuming the burning and tearing sensations are just par for the course.
If you have LS, ignoring the pain is dangerous. The rampant inflammation will hijack the body's natural healing process, using the trauma of the birth to lay down dense new scar tissue instead of healthy skin. Patients must proactively resume their prescribed steroid regimen to protect the healing tissue, and they absolutely must book a postpartum follow-up with their specialist. Treating the flare immediately prevents permanent architectural damage post-delivery.
Stepping back and looking at the entire journey from that initial murky diagnosis to navigating childbirth, we can confidently answer the core question. Does Lichen sclerosus stop you from starting a family? The answer is a resounding no.
It absolutely does not remove your biological capacity to create a family.
What it does is place a formidable, painful mechanical roadblock in your path. It rusts the front gate shut. But as we have explored through the clinical data, that roadblock is entirely manageable. With the targeted use of ultra-potent steroids to reverse the tissue changes, with expert guidance, and occasionally with some brilliant surgical engineering, the gate can be reopened.
It requires relentless vigilance and advocacy, but the path is navigable.
Before we wrap up, I want to leave you, the listener, with a final unmentioned concept to ponder. We spent a significant amount of time today discussing the Koebner response, the established medical fact that physical trauma, like friction or surgery, summons the immune system to attack the skin.
It is a clearly documented physical mechanism.
But what about psychological trauma?
Oh, that's interesting. The mind-body connection in autoimmune disorders is a frontier of intense ongoing research.
Consider the reality for most of these patients. The sources note that it often takes years to get an accurate LS diagnosis.
Yeah, that's unfortunately very common.
That means years of agonizing sex, years of internalizing the blame, years of being misdiagnosed with recurrent yeast infections, or simply being told they have a quote-unquote low libido. Could the chronic grinding psychological stress of living with an undiagnosed, intimately painful condition actually create a systemic inflammatory loop that feeds the physical disease?
We know that chronic stress floods the body with cortisol, which profoundly alters immune function. It is highly plausible that systemic stress exacerbates the localized attack.
It makes you wonder if that psychological friction is triggering its own kind of internal Koebner response.
Wow.
Right. It is a powerful reminder that when you finally get that diagnosis, treating the mind, unlearning the anxiety, the fear, and the shame is just as crucial as applying the steroid cream to the skin.
You really cannot separate the physical mechanics from the human being experiencing them.
Absolutely. So if you are holding this diagnosis, do not let a rusted gate convince you that you cannot enjoy the house. The tools to dismantle it exist. Thank you for joining us on this deep dive. Keep investigating, keep advocating for your own health, and we will catch you next time.